Black, I need you to raise your right hand. You solemnly swear to tell the truth, the whole truth, nothing but the truth, so help you God. Okay, I lost your voice. Are you muted?
I'm sorry, Your Honor.
Okay. Why don't you go ahead and state your name for the record and spell it for me, please?
My name is Wesley Black, WESLEY BLACK.
Thank you, Your Honor. Ladies and gentlemen of the jury, counsel, colleagues. Good morning, Wes. How are you?
Hey, good morning. Doing pretty well. Thanks, Janet.
Good. Are you joining us from the Pacific time zone?
Yes, ma'am.
Okay, that explains your appearance on Zoom. We appreciate your willingness to rise early and testify. Wes, where were you raised?
Grove City, Ohio.
Thank you. Where did you attend college?
I attended the Ohio State University and graduated in 2010 with a bachelor's degree in humanities. I then went back to college and attended the Mount Carmel College of Nursing. I graduated summa cum laude in February of 2018 from the Mount Carmel College of Nursing, the second degree accelerated program.
Thank you. Were you basically at the top of your class?
Yeah, I think so in a sense.
Okay. Are you currently working in a field out of healthcare?
Yes, ma'am. I'm no longer working in healthcare.
Thank you. How many degrees totally did you complete, or are you still working on education?
Just 2 degrees, 2 bachelor's degrees.
Okay. And what year did you enter nursing school?
2017.
Okay. And when did you graduate?
February of 2018.
Where was your first assignment after graduating from nursing school?
It was Mount Carmel West in the ICU.
Okay. What happened during your onboarding for Mount Carmel?
There was for me, a 15-week period of training. I believe the first week was mostly like systems, HR training, and then followed by, I think, 14 weeks of precepting in the ICU. 4 of those weeks were on nights. I believe 10 of those weeks were on day shift.
Okay, thank you. What materials were provided to you during your onboarding?
There was essentially a thick binder full of certain policies and guidelines that would be most specific to the ICU. That's what I remember.
Okay. Did you memorize that whole binder?
I did not.
Aside from what you've already told us, was there any other orientation that you received in the ICU?
During my schooling, there was a 4-week clinical rotation. I think they called it I don't remember, but some sort of, there was a 4-week period in school where we had to do a preceptorship on a unit, and I was assigned the Mount Carmel West ICU for that as well.
Okay. Now, when you were assigned to the ICU, was this in accordance with your wishes?
It may have been. I think I wanted to be placed in an ICU, but I don't remember if I requested that hospital specifically.
Okay. And who oriented you at the nighttime ICU?
During college
No,
or in general?
I'm turning to when you actually accepted that position and started working. Was there further orientation, and if so, who did it?
If I remember right, there were a combination of maybe 10 nurses that precepted me on the night shift. It was almost a different person every night. Maybe we'd be together for 2 or 3 nights, and then someone else would take over. I think it was mostly a scheduling, kind of coordination.
Okay. At the time, were you comfortable with the orientation you were receiving?
Yeah, I think it was a challenging environment, and so it was. It was challenging at times, but I believe I was comfortable with that.
Okay. Were the practices of the various physicians provided or discussed?
During that time, I believe so. I think on the night shift ICU, Dr. Husel and Dr. Hagris were really the only doctors that worked the night shift, and so they each had certain things, medications or practices or that they liked to do that may have been a little bit different. Maybe things they did the same as well, but we would have discussed because a big part of the job was being prepared for what the physician may need or order next.
Okay. Was there a palliative care physician that worked at Mount Carmel West on the night shift?
Not to my knowledge.
Did you ever see one or talk to one?
No, no, not on the night shift.
Turning now to the doctors that were assigned to the ICU at night, do you have an opinion based on your experience with them as far as their approaches to dosing or medications?
Dr. Husel was known for more aggressive treatment of medications and dosing.
What were their approaches to teaching or sharing knowledge on the unit?
Dr. Husel was certainly known for teaching. I remember during preceptorship, they would have him sometimes, if it was a more quiet night or more quiet part of the night, ask him to teach about ventilator settings and how that related to patient care. I remember that from the training.
Okay, thank you. Let's turn to staffing on the unit right now. Were there any outstanding staffing issues that you were aware of during your time there?
It seemed like it, in a sense that, in general, nurses are, in high demand, or were at the time, and so a lot of the nurses that gained experience on the ICU would move on to travel nursing or graduate school, and so a lot of the nurses were quite new to the field, and a lot of time I think they kept shrinking sort of the ICU from multiple specialties to more and more narrow, just having one unit for everything, and then we even staffed the step-down ICU as well, which was in a sense a break in patient care because we would work maybe 1 or 2 shifts in the ICU and then move up to the step-down ICU, and instead of maintaining kind of our same patient load in the ICU consecutively, if that makes sense.
Sure. Let's take a step back. Do you remember the exact dates that you went to the ICU and when you worked your last shift?
I don't.
Can you approximate?
I think my last shift was probably sometime in mid-December.
Okay, what about your first shift? What month?
My first shift would have been March of 2017.
Okay. Thank you. Did the move to Grove City, or the pending move to Grove City, create any special issues that you were aware of?
I think the main thing with the move to Grove City was that the unit was going to be a combined sort of step-down ICU and comprehensive ICU in Grove City. And so there were essentially the main ICU at Mount Carmel West and the step-down ICU, which were on different floors, were all managed by the same staff. So that would have been the case. I think that would have been the main concern.
Okay. Can you describe the experience level of the nurses that you worked with while you were at the Mount Carmel West ICU?
I would say there were some very experienced charge nurses that had been working in the hospital for a number of years. There were maybe a couple outside at the hospital.
Okay, hold
in
on.
the ICU.
Hold on, you're fluttering on us. Do you want to re-ask the question?
Yes. Can you repeat your answer, please, Wes? You fluttered a little bit.
The internet connection?
Yes, yes. It gave us a little trouble there.
Understood. I'm sorry, you may have to re-ask it.
Okay. Can you opine, or can you tell us about the experience level of the nurses that you were working with?
Yes, thank you. So there were, I think, 4 or so nurses that had been working on the unit for, 5, 10 plus years. They were charge nurses for the night shift ICU. I think there were maybe a couple of other nurses that had been working on the unit for 3 to 4 years. I would say the majority at the time I was working there were probably 2 years or less experience as a nurse or in the ICU.
Okay. And when you say the majority, how many nurses are we talking about?
I think there were probably maybe 25 nurses, if I had to put a number on it, 25 to 30 that worked on the night shift. And, I would say 15 or so had maybe 2 years or less experience, either in nursing or in the ICU,
Okay.
or both.
Thank you. Going into the unit, how much coursework did you have in pharmacology?
I had a 1 course in pharmacology. It was an 8-week course that covered everything from alternative medicines to, basic vitamins, and maybe any medication that a nurse could potentially run into. It was a very general course.
Thank you. Were you taught how drugs worked on a metabolic level?
No, we were not. It was mostly just general indication of the medication and maybe some side effects to watch out for.
How about dosing? Were you taught dosing?
No.
How about conversion tables from one opioid to the next?
No.
Was there a geriatrics course?
There was.
Okay, and how extensive was that?
I believe it was a 4-week course. I wouldn't say that it was extensive.
Okay, thank you. What about palliative care?
I believe there was maybe a 1-hour seminar, maybe 2-hour seminar that we would have done through our training at Mount Carmel. In the there was I guess I didn't mention this. There was some sort of new nurse program at Mount Carmel in the Mount Carmel hospital system where we would meet maybe once a month for a seminar for the first year.
Okay.
So I think that was one of the meetings we had. It was maybe like a 2-hour seminar on palliative care, something like that.
Thank you. During the course of that palliative care training, was there discussion about the use of narcotics for palliative patients?
I believe there was.
Okay. And was there a discussion about not being afraid to use comfort measures?
I believe there was. I believe there was some discussion about, a lot of times these patients are in a lot of pain and, don't be afraid to, give pain medications. Sometimes it may be even more, I think there was a comment saying, sometimes it may be even more than you're used to giving, but, there's this sort of a painful process in the dying process.
Okay, thank you. Did they quantify that or type it as far as how much to give or what type of illness?
No, ma'am.
Okay. At the time you were working at the ICU, had Dr. Husel or anyone else discussed the synergistic effects between drugs?
Not that I recall.
Do you recall making statements after you left the unit that the concept of synergistic effects was not one that you were familiar with?
Yes, I have reviewed that in some of the transcriptions from interviews.
So you would agree with that statement that?
Yes, ma'am.
Okay. Was anyone teaching you the basics of how fentanyl and Versed work together or separately?
I think my perception of that was that fentanyl was mostly for pain management and Versed was mostly used for anxiety. Those were the classes of medication. Of course, they may have some sort of crossover, but that was my understanding, I believe.
Okay. Were you aware of hospital policy at the time you were working in the ICU regarding palliative withdrawal of ventilation?
I was not familiar with any sort of policy with palliative care that I recall.
Thank you. Was there emphasis on charting accuracy or eliminating or holding back charting to a minimum?
Yeah, I believe so.
Okay. Was there training on a one-nurse procedure as far as obtaining, preparing, and administering narcotics?
No, as far as the training, it was a very collaborative environment in the sense that, you know, sometimes there are very sick patients that need a lot of attention, and it would be, you know, impossible for just one person to tend to all of their needs. And so it was sort of a teamwork approach. So from day one, we were, I mean, at least trained that, you know, multiple nurses could work together towards the same goal.
Okay. Is it your opinion that that was the culture on the unit?
Yes, I believe so.
Who do you believe set that tone or set that culture?
Objection, also speculation.
It does, sustained.
Were you taught best practices for teaching family members how to interpret the actions of the dying?
I don't believe so.
And were you taught hospital policy for medication retrieval?
So knowing what I know now about the policies, I don't believe that that was information that was really gone over in great detail, if that's helpful.
Stop, sir.
Your Honor, I believe that's a perfectly appropriate question. What he knew at the time as far as hospital policy for the medications that he was retrieving.
He's referring to what he knows now.
Well, let's rephrase the question, focusing on what your question's intent was,
Thank you.
okay?
Wes, at the time that you were working at the Mount Carmel Hospital ICU, were you aware of hospital policy for medication retrieval?
I don't think I was.
Okay, thank you. Let's turn our attention to pain scoring and determining a patient's status. What tools did you use to determine pain scores?
There were a number of scales, verbal, visual, and I believe the CPOT scoring as well.
Okay. Was that the primary one you were used to using, the CPOT? I think he froze.
Yeah, I think he did.
Yeah.
There, he's back.
You're
Maybe.
back. Can you hear us, Wes?
I'm sorry, can you hear me?
Yeah, you just froze for a sec. Did you commonly use,
Okay.
okay, I think we discussed the CPOT. Did you use anything other than the CPOT?
Not that I recall. I mean, the visual and verbal, you know,
Okay.
would have been pain scales.
All right. What is the scale of the CPOT? What numbers are used?
It's a range.
Yeah.
It's a range from 0 to 8.
Okay,
I
already?
think there are 4 categories that can be ranked from 0 to 2, and then you add them together for the cumulative score.
Okay, thank you. How often were you generally expected to work on a patient that was in your care?
It depended on the orders to that specific patient.
Okay, so what was the minimum or the maximum?
Typically, there was in the ICU, I believe, a standing order to assess the patient every 2 hours. certain, disease process, it may be as much as every 15 minutes. But 2 hours probably would have been the maximum amount of time. Now, there was a 1 hour sort of variance within that. So if you had a 9 o'clock assessment, you could do it as early as, 8 o'clock. And if you had an 11 o'clock assessment, I guess you could do it at potentially as late as, 11:59 in a sense, but I think I'm getting too much into the weeds.
Okay.
Typically, it was every 2 hours.
Well, we're into the weeds anyway, so you're not alone.
Okay.
Okay, and would this assessment be tracked during the day? In other words, would you go to a computer terminal and put in what you found for that patient through the day?
That's correct. It was not my practice to leave that until the end of the day.
Okay,
Especially maybe the nurses who were used to paper charting before the electronic record. They would sort of sit down at the end of the day and chart everything that happened. But in my training, it was more, in the moment, or as much as you could. Of course, when you're assessing, you can't chart simultaneously, but you can do it shortly after.
okay. Would pain scoring be one of the things that you charted during these routine assessments?
I believe so.
And would this all be kept in one place by category? These charting observations?
Yeah, I believe it would just all be in sort of an assessment page on the computer software.
Okay. Would you describe for us what that's called and what kind of elements are in that portion of the medical record?
Ooh, it's been a few years since I've seen, but the software that we used at the time was called PowerChart.
Okay.
And within PowerChart, there were a lot of different sections you could utilize. Progress note, like critical, was another one. There were different notes you could write. There were different, and then the main one that was used for that was just some sort of assessment section, and there were probably maybe 5 or 7 pages to that, and you would kind of go down, and maybe the first page was like a skin assessment and cardiovascular assessment, and the second page was musculoskeletal assessment and neuro assessment and pain assessment, something like that. And you just sort of went through and charted specific characteristics of the patient that were generally expected in that ICU.
Okay, thank you. So if someone was going to review an electronic medical record, there would be a section that had nursing notes in it by different categories. Is that a good summary?
Yeah.
Okay. Describe what the pain scoring section would look like.
It looked sort of like an Excel spreadsheet. You would maybe had 2 or 3 lines, say, time column. This is the pain scale, and this is the pain rating based on that scale.
Okay. And would it, if someone were in the hospital for, say, a week, would you have dates and times listed along the left column, and then you could read it over as far as what was going on with the patient at a particular day or time?
Yeah, I think it would be difficult to see like a comprehensive, I could be wrong, but a comprehensive view of every pain score that had been received. It was typically like a 12 to 24 hour view. And I'm sure you could kind of manually go back further if you wanted to, but probably only really be seeing maybe 24 hours of assessment on the surface level, unless you really wanted to start digging. Could be wrong about that, but that's my recollection.
We're going to dig in just a minute, so let's move on. Would you need to enter a pain score to enter a medication order for opioids or benzodiazepines?
So I believe when you were giving the medication, not necessarily entering in an order, but when you were maybe signing an order, you'd have to give a pain score for any pain-related medication, I believe.
Okay. What were you taught on the unit about pain scores and pain scoring in your patients?
I think at times the pain scoring was maybe not specific to, say, the CPOT scale. I think, there were times where you sort of learned that it was difficult to tell if someone is in pain. Of course, if they can speak or give you a visual, then that's a little easier, right? But in the ICU, oftentimes that wasn't possible. So you were trying to maybe just take in the entire clinical picture of what that could be. And then typically that was entered as a CPOT score. So you would see a lot of folks in their charting maybe enter a 10 when they meant, a lot of pain, even though the scale only went to 8. I had someone tell me that it only went to 8, so I typically capped it at that, but is that helpful?
That it's responsive. Did you rely on physicians to assist in ascertaining a pain score?
I think we relied on their knowledge and experience, but the assessment was the nurse's assessment.
Okay. Was it common practice for the nurses to enter a high pain score before an extubation?
I believe it was, in the sense of it was typically a time of, potentially a painful process.
Okay. Does the term anticipatory pain mean anything to you?
Yes. So when giving a medication, for a palliative withdrawal or extubation, the medication was given sort of preemptively, or you could call it a pre-medicated medication. So I think that would kind of line up with an anticipatory pain score as well. And that was something that was in the practice at Mount Carmel.
Okay. Does that differ at all from currently experienced pain as observed?
Yes, I believe so.
Have you observed Dr. Husel discussing the dying process with families?
Yes, ma'am.
Okay. Did you have discussions with Dr. Husel regarding his end-of-life discussions with families?
I did.
Okay. Did he express that he had goals for being better at it?
Yes, he did. Yes.
What was your reason, what was your understanding as far as the reason that he was working on it?
I don't know. I don't know specifically the reason he was working on that.
Was he known to set goals for himself?
Yes, I did know that that sort of conversation with the family revolving around the palliative withdrawal of care. That was a goal for 2018. I remember in 2017 he had set a goal for becoming better at difficult intubations. There was a certain tool that he used a lot during that year to try and improve with difficult intubations, improve the patient care. And from what I recall, in 2018, sort of one of his personal goals for the year was to improve the process for the palliative extubations. And that was something he was trying to improve that process, I think, in his practice.
Thank you. Did he have a name for that?
For the goal setting, I don't think
process.
so. Not that I recall.
Okay. Did he have difficulty speaking in groups?
I think so. At the time, I think he was sort of trying to get better at speaking to, families and in groups as well. So that was part of the process, part of the goal, I think.
Was your observation that he sometimes lacked confidence?
Confidence in public speaking?
Yeah.
Or
Speaking in groups?
yeah, I think so. I think it wasn't something that came as natural as speaking in, one-on-one or in small groups.
How would he present options to families?
So typically, in the palliative context, is that what you mean?
Yes.
Typically, there would be, kind of two options. One would be to remain, for the patient to remain on life support in full sort of aggressive, ICU care. And the other option would be to withdraw that care and make the patient comfortable and able to, take their last breaths on their own.
Was there ever a time when your size was referred to as part of the options?
There was.
Okay, stop. Sustain and rephrase.
Okay, thank you. Wes, we can't tell from, oh, he's frozen. We can't tell from the Zoom what size individual you are. Can you tell us a little bit about your size?
Objection.
Not permitted.
I'm a pretty big guy. I'm at 6'4", probably 240 pounds, something like that.
Okay. Was your size in providing CPR ever invoked?
There was, during a palliative conversation, when Dr. Husel was explaining, I think, how CPR can be a painful process. And so when presenting options such as aggressive ICU care, if someone's heart were to stop, someone will have to do CPR, like the nurse who's, 6'4", 250 pound, pushing on the chest, and it can break ribs and it can be very painful. that is something that is part of CPR and part of the full code status.
Okay, thank you. How much time did Dr. Husel spend teaching families about what to expect during the dying process?
I don't think that,
Objection.
Thank you. Did you spend time with Dr. Husel while he was speaking with families running up to an extubation?
I was in one palliative conversation, I believe, with Dr. Husel.
Okay. And how much time did he spend during that conversation teaching the family what to expect during the dying process?
I don't recall that being part of it.
Okay, no. Was there discussion about agonal breathing or respiration anomalies during the dying process?
I don't believe so.
Okay. Wes, we're going to turn the page now to some actual patients in your practice. We're going to ask for patience as we do this, because we're going to go split screen and show some things to you and to the jury. And I haven't done this before. My lovely co-counsel has volunteered to help, and we'll see how we go. Okay, so Wes, do you recall a patient that you assisted on November 19th of 2018 in the ICU?
I believe that was Rebecca Walls.
Thank you. Was this your patient?
She was under the care of a nurse named Jordan Blair.
Okay, thank you. And how did you become involved in her care?
So Jordan was assigned a new patient. It was in a very emergent situation, and he was made aware that they were en route to the unit, and he needed to sort of focus his energy there. Dr. Husel was also going to be needed during that time, and so I had been watching Jordan, calling the family member or POA of Miss Walls, and caring for Miss Walls all night. And I know that he had been preparing to do a palliative withdrawal with her. And so I offered to sort of take the reins while he was taken away to his other new patient. That makes sense?
It does. Did you observe the decision-making on the DNRCC in that case?
I did not.
And at what point did you enter the picture? What needed to be done when you entered the patient's care?
Just the process of extubating and medicating patient. We would also sort of clean her up and remove any medications, or there was also a continuous renal therapy as well, sort of like a dialysis. So all of those sort of life-saving measures were to be stopped at that time pursuant to the code status change, and then also giving some medication for comfort.
Okay, thank you. We're going to turn now to the medical record. Corinne, if we could go to the orders on 365, medication orders.
I apologize. I haven't been given anything of what she's going to show, Mr. Black.
It's
Exhibits.
it's it's all out of the medical record. I can,
Show it to him before you show it to the witness.
It's pretty up
no, because he's on Zoom and we just decided to do it all electronically. So, we all have the same pages. Can you?
Yeah, well, I can pull up an interim, can we not do that first?
Sure. Yeah. Do you want this list?
Sure.
Okay.
Do you have a copy of the list?
Yeah.
Janet, just write the page numbers down.
Got it? Okay. Thank you. I'm sorry. I figured you guys would be on it. I know, it's so cumbersome. So we're going to med orders page on. This is Penix's inpatient meds list. And the actual numbers of orders are,
Yeah.
you know, that's a mystery. Yeah, we're down the deep hole in that one. Sorry, Your Honor. Okay, how are we doing? Can we go back to, yeah, 365? Okay, would this be 13? Do we want to use a letter? We already. Okay. Your Honor, with the court's indulgence, we're just going to refer to this as Exhibit 13, page 365, rather than go into letters, unless the court would want us to utilize letters.
It's just identifying for the record.
Okay, thank you. Wes, what does this look like? Can you see the exhibit?
Yeah, it looks like a medication order.
Okay. And what is it for?
It's looks like an order for fentanyl for Mrs. Walls.
Okay. And Corinne, can you kind of get the whole picture? Yeah, there we go. Okay. And does it appear that the medication order was not reviewed by pharmacy?
Yes.
Okay. Can we drop down to the midazolam portion? Same situation. Does it appear as though it was not reviewed by pharmacy?
That's correct.
Okay, thank you. Let's turn now to page 561, 62, Exhibit 13, Rebecca Wall's electronic medical record. Okay, Wes, what does this look like?
So this is some sort of, it says flow sheet. It's a flow sheet. So this is more of a comprehensive list of pain scoring,
Okay,
oxygen delivery, and so this wouldn't have been like the view that we had on the electronic record, but this would be reflective of just sort of those two items.
okay. Could you go down a little bit more to, yeah. Yep, there we go. Okay. So is this what we were talking about before where in the electronic medical record, there's a section, and then that section is entitled for some subject, and then the dates and times run down the left, and it appears like an Excel.
Yeah, this isn't what we would have been seeing, but this is sort of a just a I'm not sure what I'm trying to say, but it's just showing the pain score, whereas I would have been able to see hundreds of different items like that.
Got it.
As far as assessment.
Okay, got it. So this is the organization in the EMR, not the input page.
Thank you. That's correct.
Okay, so let's look at Ms. Wall's pain scoring. It looks like she's ventilated, and then at 1:26 on 9/11/2018, you come in and enter a pain score. Is that correct?
That's correct.
And what pain score did you enter?
It's an 8.
And why did you enter the 8?
It's been some time, but from what I remember and what I've reviewed, I believe that, this was a patient I was told was in a lot of pain and was receiving medication for palliative extubation. This pain scoring would have been in conjunction with giving that medication. And so the patient was in their condition, I was told that can be sort of the dying process for that patient was potentially very painful. And so that's why we were giving that medication. So that score would have been in conjunction with that same time that the medication was given.
Was that pain score entered based on your observation of the patient or anticipatory?
I can't say for sure, but I would say it was most likely a mix of observation and anticipatory.
Okay. And you see that up until the point where you put in the pain score, it's all zeros, right?
Yes.
Okay, thank you. Let's turn to page 1000. What is this, Wes?
Medication administration record, or the MAR,
Okay,
or Mrs. Walls.
okay, let's try to go to 1001. There we go. Okay. These two entries for fentanyl and Versed, what do those appear to say?
As for the dose, 1,000 micrograms IV push, pain score 8, ordered by Dr. Husel and performed by myself. And for the midazolam, it was 10 milligrams IV push, ordered by Dr. Husel and given by myself.
Okay, thank you. So that can actually come down. Did you go to the Pyxis machine and withdraw this medication?
I believe Jordan withdrew the medication
Do you have any idea?
from the Pyxis.
Okay, all right. Did you administer the medication?
So there was another nurse with me at the time. I'm not sure if I administered the medication or not, but the medical record does reflect that I I signed that medication, and so that would be under my name.
Okay. Who removed the breathing tube?
I can't recall. It would have been either myself or the other nurse.
Okay. Who filled the syringe? Do you know?
I believe that was Jordan Blair, but it was a few years back now. I don't remember exactly.
Okay. Who ordered this medication?
Dr. Husel.
Was there a problem from pharmacy on this case?
The pharmacist did not verify it. They actually had rejected the medication order.
Okay. And what happened relative to that rejection? Was there discussion?
Not with me. So when I knew that Dr. Husel wanted to give that medication, he had told me the dosage, and he had said that he had put in the order. He said that a couple of times. I put in the order. This is the order. You're good to go. He said that multiple times to me, and so I knew I was very clear on the order to be carried out. And so when the rejection from the pharmacist, I did see that, but it was under my understanding that essentially they would just need some more information from the doctor to sign off on that. And the Dr. Husel was not available at that time. I understood this to be a very time-sensitive thing, since Mrs. Walsh was, that would have been her wish, was to be taken off the ventilator, and her condition was declining. So I believe the pharmacist never reached out to me, and my assumption was that he did reach out to the doctor at some point when the doctor was available.
Okay, so the nurses administered the medication, correct?
That's correct.
Okay, either you or Ms. Bond?
That's correct.
Okay. Had you ever done a palliative extubation with Dr. Husel prior to this particular treatment?
No, ma'am. I would have been in proximity while it was going on, maybe with other patients in other rooms on the unit, but I was never directly involved.
Okay. Were you alarmed at the dosage used?
So I was aware of similar situations and similar doses. It was a lot of medication. It was the most medication that I had given of those classes. But my perception of Dr. Husel was that he's very regular. In a sense, he would do the same processes. He would kind of improve these processes and do them the same way every time, and maybe change small things based on the patient care. And so since I knew that similar doses had been given, I perceived this to be the standard for his practice. And, being that I was a new nurse, being in new situations in a comprehensive ICU, that was not an unfamiliar feeling. I was doing new things all the time for those years.
Okay, thank you. Wes, did you work the next night, November 20th?
I did the next 2 nights, actually.
Okay, all right. And were you assigned a patient by the name of Melissa Penix?
I was.
Were you on unit when Melissa Penix was placed on a ventilator?
No, ma'am.
What was going on with Mrs. Penix when you arrived on unit?
So her condition had stabilized. She had been rapidly declining and intubated emergently. And it was a very, very busy shift taking care of her. From what I understood, the nurse prior to me was still doing a lot of charting and catching up with that when I showed up.
Okay. And did you interact with the family?
I did. There was Mrs. Penix, I believe it was her husband, and her granddaughter at the time were in the room.
Did you explain any of the process or equipment or any of the treatment that she was receiving at that time?
It's certainly possible, but at the time, Mrs. Penix was stabilized, in my perception, and so I think it was just more of being a comforting person in that situation. That they'd had a pretty stressful day.
Okay. And at some point, did it become close to dinner hour?
Yes, of course. So being that they had a pretty stressful and a long day, I suggested that they go home and rest up, as Mrs. Penix seemed to be in stable condition. She had stable vital signs and, seemed to be, resting at the time.
Okay, thank you. What happened after the family left?
So shortly after the family left, Dr. Husel and the nurse who was shadowing him for the night, he was a nurse practitioner student, was shadowing Dr. Husel for the night. They came into the room. They had just seen a recent lab value showing that Mrs. Penix was most likely still in a declining state and maybe her condition would become very unstable very quickly.
Okay. And was there a problem around the IV site?
There was. She was bleeding sort of profusely. I had to change her dressing multiple times. So there was quite a bit of blood sort of filling that up. And so I remember working on that quite a bit that evening.
Okay, thank you. Was there a time when another nurse called the family back to the hospital?
There was.
Okay. And why was that?
The patient was certainly declining, and death seemed to be potentially imminent. And so that nurse was very experienced. That was one of the charge nurses, and she perceived that the family might want to be present in case these were Mrs. Penix's final moments.
Okay. How many family members came at that time?
My recollection would be maybe 6 to 8 family members, including the husband and granddaughter from earlier,
Okay.
and then maybe a few children of Miss Penix and their spouses. That's my recollection.
Okay, thanks. Let's go to Ms. Penix, med orders, States Exhibit, or Joint Exhibit 14, however we're going to call it, pages 325, 326, medication orders. And we'll want to go to the intubation set. Let's back up. We want to go to the set where she was intubated. Which basically should start around 1953. Yep, keep going. Yeah, those are all discontinued. Let's go to the next page. Forward, Corinne, thanks. We're looking for 1953. Okay, hydromorphone, let's start there. Wes, I'm going to show you the med orders, the order date and time, 11/20/2018, 11:53. And can we review those for him and then have him tell us what they're for? There's hydromorphone, ketamine, and Versed, I believe, or should be.
You want him to review the page? Is
Um,
that what you're asking him to do?
Yeah, I'm asking for a scrolling, and then at the end, we're going to wrap it up. Okay.
Judge, I don't think there's a foundation. These are other doctors' orders.
Well, he was certainly there for them.
Okay.
We can go to the administration record if you want.
Objection to overrule as the foundation stipulated in the record. So let's go ahead and ask the questions or refer to where you want to go.
Okay, thank you. So Wes, when you see hydromorphone, ketamine, Versed, and some paralytics, what do you think's going on?
This would have been given most likely to relax the patient on the ventilator. So the
Okay.
ventilator could be, taking over her respiration
Okay.
appropriately.
Okay. Let's keep scrolling. And keep scrolling. Scroll, sorry. Yeah, we're going to stop as soon as we get to the paralytics. Whoa, 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 whoa. Okay, keep going. Morbidazolone, okay, keep scrolling. We're looking for 2110. Okay, so the Vicurium, which I cannot pronounce, what is that?
Becuronium.
Yes.
It's a
thank you.
paralytic.
Okay, thank you. Looks like that was ordered. Next entry, please. And Nimbex, what is that?
I believe that was also a paralytic.
Okay, thank you. Let me take that down, take the orders down. Let's go to Exhibit 14, the MAR, page 739. is that? Okay, that's 7:39. And what were those orders given? The hydromorphone, does it appear from the medical record it was given?
It looks like it was given by another nurse.
Okay, what's the pain score there?
9.
Okay, thank you.
Judge, can we point out the time? I think
I'm asking you to fill in a little more foundation.
Okay, thank you. What time is there, is listed there, Wes?
It's 2 different times. The administration date and time would have been, time would have been 1750.
Okay.
It was charted at 1958.
Okay. 1750 is almost 6 o'clock at night, right?
That's correct.
Okay, all right. Let's go to page 744 in the MAR. Okay, stop right there. Does it appear as though at 2200 that the Nimbex was administered?
Yeah, 2201 it looks like, or 2200, yeah.
Okay, and did you administer that Nimbex?
Yes.
Okay. Also on that page, dropping down at 2248, is an order for a 2,000 microgram IV push of fentanyl and 10 milligrams of midazolam. Do you see that?
Yes.
Was that ordered by Dr. Husel?
Yes.
Do you know for a fact that he ordered that?
Yes.
You heard it?
Yes.
Okay. So let's turn back to what's going on in the room. Who retrieved Dr. Husel to speak with the family?
I believe I would have called him.
Okay. And did he come to the room?
Yes.
What options were offered to the family for continued care?
I believe he told them that there were, a couple of options with care. We could continue to aggressively treat Ms. Penix, or we could withdraw care.
Okay. And is this, was your size invoked during this conversation?
Yeah, that's when he was sort of explaining what would happen if her heart were to stop, and I would have to do compressions.
Okay.
I think the idea was to say it was a painful process.
All right. Did Dr. Husel ever instruct you to check the patient for the effect of the paralytics before she was extubated?
No.
Who retrieved the medication?
I believe I did.
And was this retrieved on override, Pyxis override?
Yes.
Was there pharmacy approval for it?
I don't believe so.
Do you know who drew up the medication? Who prepared the syringe?
I believe I did.
Okay. Do you know who administered the syringe?
It would have been me or the other nurse, but I did sign for it, so the
Okay.
record reflects that I did.
What was the name of the other nurse?
I believe it was Santos.
Okay. Was the medication administered through IV push?
Yes, ma'am.
Okay. When was the family allowed to come back in?
Objection.
So after,
I'll rephrase it. After you administered the medication, what happened?
we would have removed any sort of life support, including the breathing tube, the medications that were on drip, and made Miss Penix comfortable in bed, cleaned any, blood or fluids that may have, been visible, and then allowed the family to, ask the family to come back into the room and spend some time with her.
Okay, thank you. Do you know how much time elapsed from the telephone call to when she passed?
I don't.
Okay, all right. Two more items, and then I think we're close to done. Can we go to page 473 in the electronic medical record? Okay, let's, okay, there we go. So, back to the medical record. What does this look like, Wes?
So this would be a pain score.
Okay. And does the afternoon and evening hours of November 20th of 2018 appear?
Yes.
Okay. Now, let's turn our attention to 1750, where there is a pain score of 9. That was apparently charted by a nurse other than you, correct?
That's correct.
Okay. And then there are 3 entries from you. What are their times and what are they?
It's a pain score of 0.
Okay. And the times are 2024, 2037, and 2122, correct?
That's correct.
And what pain score did you enter as you were administering the 2,000 mics of fentanyl?
It's a pain score of 8.
Okay. Did Mrs. Penix's physical condition change dramatically between 2122 and 2248?
I think that the medication was given, the pain score was given in conjunction with medication. So this would have been, again, around that time of withdrawal.
Okay.
In anticipation of the withdrawal, I believe. So I can't say for sure, but I don't recall anything specific changing from 2122 to 2248.
Thank you. Let's go to patient record on page 48. Okay, we're going to need to back up a little bit. What does this appear to be?
medications that the patient would have been given during the hospital stay potentially.
Okay, thank you. Let's scroll down a little bit. There's a morphine entry, is there not?
That's correct.
Would it be appropriate in your practice on the unit to review inpatient meds routinely?
Potentially. A lot of times that was done sort of in the intake of the patient when they were moved onto the unit.
Okay,
But I probably would have been made aware in the nursing handoff that morphine is a medication that she takes at home.
okay. And this is 15 milligrams twice a day, correct?
It's sort of an extended release, sort of,
Okay.
I believe.
Okay. And would it be appropriate for all of the medical professionals on unit to take a look at this before ordering further opioids?
It would more be, of course, it would be good to keep that in mind. It'd be more on the physician's radar.
Okay, thank you. And sir, just to recap, the two patients we're talking about and the boluses or the IV syringes for 1,000 micrograms plus Versed and 2,000 micrograms plus Versed. To your knowledge, both of those syringes were administered to patients' Walls and Penix.
Yes, ma'am.
Each, 1,000 Walls, 2,000 Penix, correct?
Yes.
Okay, thank you. I have no further questions.
Ladies and gentlemen, the jury, let's take a break. It's been 10:30, 15 minutes. We'll get started at 15 till. And Dale? Okay, that's what you call one.
All right.
And remember the admonition.
Mr. Black.
Hey, good morning.
Sir.
Hey, doing all right, thank you.
Now, this is the first time we've had an opportunity to speak, correct?
That's correct.
Okay. I'll try and ask my questions clearly and loudly, not, of course, I'm not going to yell, but if you don't hear my question or you need me to repeat it, I'm more than happy to do so, okay?
Okay.
All right. You were started at your training, so that's where I'm going to start with you as well. Is that okay?
Yes, sir.
All right. Now, you talked about you had done a certain amount of precepting when you started. Is that correct?
Sure.
Okay. And prior to you doing this extubation, and just to be clear, you were working at the ICU for almost 2 years when you did the one extubation and also, actually both of these, right around 1 year and 10 months. Is that correct?
Yes, sir.
So you weren't, while you were a young nurse there, you certainly weren't new, right?
Yeah, so there was a 2-year mark was kind of when you were considered experienced enough to begin training other nurses. So I was just under that.
Okay.
But I'd been there for a while.
And during your training, you had done approximately 12 palliative extubations, correct?
Yeah, so I would have been precepting with a nurse on the day shift.
Right, so this wasn't something that was foreign to you. You had the opportunity to be exposed through it throughout your training, correct?
That's correct.
All right, and you talked about this palliative withdrawal training that you received. I guess it was a course given by someone from the palliative withdrawal team? Or palliative care team, excuse me.
Yeah, I don't think that the entire course was directed at palliative withdrawal, but sort of end of life care in a sense.
And in that class, you were taught that, and I want to make sure I get this right, every patient is different. Don't be afraid to give larger doses of medication. I know it seems uncomfortable at times. Correct? You were trained that by Mount Carmel?
That sounds correct.
And that training was conducted by someone from the day shift, correct?
I believe it was a nurse practitioner on the palliative care team on the day shift. That's correct.
Okay. And she, in fact, told you that I've given enough to put down an elephant. Do you recall that?
Object. Hearsay.
It's not being offered for the truth of the matter asserted, Judge.
What's it say?
Effect on the listener. It was his training. You can answer.
My memory is a little bit fuzzy, but that's certainly in previous records that I've stated that.
Okay. So you recall telling the police that that's how you were trained, correct?
I believe that's what it said in the, and I believe that's what I said in the interview. That's correct. I don't remember it exactly.
And of course, the prosecutors were there, right?
They were there when I was speaking to the police. It was,
Object, Your Honor, that's, may we approach?
Yes, you may.
Yes, Judge. Just to be clear, you had a initial meeting with homicide detectives, correct? You have to say yes.
I did have a meeting.
Okay. And then,
He said, did he say you have to say yes?
That wasn't what I heard.
Okay.
well, he was nodding his head. I was telling him
Okay.
you have to verbalize it, for the record.
So I did have a meeting with the police detectives.
Okay. And then, after that, you had another meeting where you were present, your lawyer was present, and then you had some homicide detectives present, as well as the prosecutors, different prosecutors than these here, correct?
That's correct. They were different prosecutors.
Okay. And you had made it clear that this was your training, correct? By Mount Carmel.
Yes, sir.
Okay. Now, there's been a lot of talk of palliative withdrawals in this trial for understandable reasons, but palliative withdrawals were in fact not common in the nighttime ICU, correct?
Yes, that's correct.
In fact, the entire year and 10 months that you worked with Dr. Husel, you only did one with him, correct?
That's correct. I participated in both of these, but only one was with one of my patients. So it was a very, very small percentage of what we did.
You say it's a small percentage of what you did. The fact is that in that year and 10 months, hundreds or close to 1,000 of lives were saved while you were there, correct?
Yes, I believe I cared for hundreds of patients during that time.
Okay. And it wasn't all palliative extubations and people dying, correct? That's, I guess, what I'm...
That's correct.
Okay. And you understood that Dr. Husel was aggressive in basically everything he did, correct?
Yes,
He was aggressive in the care that he provided for his patients, correct?
yes, sir.
He was aggressive with the medications that he gave, correct?
Yes, sir.
And he was aggressive with the doses he gave, correct?
Yes, sir.
And you would classify Dr. Husel as hardworking, would you not?
Absolutely.
Okay. And in fact, Dr. Husel was always available to everyone on the ICU floor, correct?
That's correct.
And in fact, he was rarely in that room that you call the call room, correct?
Yes, that's correct.
And when he wasn't aggressively treating patients, night in and night out, he would, on slow nights, teach the other members of the ICU team, correct?
Yes, sir.
All in an effort to give better quality of care to the patients that came through the ICU.
Is that a question?
Correct?
Okay. She was right until you added the correct to it, so I'll permit the question to stand there with the correct.
You can answer, sir.
Yes, at that time, I believed that everything he was doing was to better the care of the patients in that hospital.
Okay, and in fact, all doctors are different, right?
Yes, sir.
For example, Dr. Hagris, who you worked with as well, right?
Yes, sir.
Dr. Hagris would spend a lot of time in the call room, correct?
I believe so, sir.
Much more time than Dr. Husel, right?
Definitely.
And you were aware that, and this was from working with other nurses, that these doses these aggressive doses had been done there for years, correct?
Object.
Sustain, let's lay some foundation.
Sure. Mr. Black, you're aware, you worked with nurses that had been there for years, right? Everybody wasn't new.
Object, Your Honor. Context,
Permitted
please.
so far.
I'm sorry?
I said
Right.
permitted
Is-
so far.
Go ahead, you can answer, sir.
Yes, sir, there were nurses there that had worked on the unit for years.
In fact, I'll just name a couple. Beth M.Q. had been there for 30 years.
Yes, sir.
Ann Irwin had also been there for 30 years.
Yes, sir.
Sharon Suber had also been there for 30 years.
Yes, sir.
Brandy Wells had been there for 15 years.
Yes, sir.
Akila Bowens had been there for over 5 years.
Yes, sir.
And of course, Tyler Rudman also was there for over 5 years.
Yes, sir.
So you would often lean on these more experienced nurses as you were learning throughout the process, correct?
Absolutely.
And some of the things you would discuss, of course, would be medications.
Yes, sir.
Permitted so far.
And that included the dose amounts of Dr. Husel, correct?
Yes, sir.
Okay. So it was no secret that Dr. Husel was aggressive in his pain meds.
No, it was no secret.
You never witnessed Dr. Husel attempting to hide that in any way, shape, or form, correct?
No, sir.
Now, you talked about anticipatory anesthesia. That, of course, was how you were trained by Mount Carmel, correct?
Yes, sir.
Okay. And when I say anticipatory, I'm referring to anticipating the pain when giving palliative withdrawal pain meds, correct?
Yes, sir. In every palliative extubation that I witnessed, that was a practice.
Okay. And the reason is that the goal at this point is to provide comfort to the patient, correct?
Yes, sir.
And these could very well be the last moments of a patient's life, and you're aware of that, correct?
Yes, almost certainly the last few moments.
And the thing that you want to do is get ahead of the pain, correct?
Yes, sir.
And it's not to hurt the patient, right?
Of course not.
Okay, so, of course, another aspect or benefit of getting ahead of the pain is that the family members, in witnessing their loved one's last moments, would not be ones where they're witnessing suffering, correct?
Sustain.
Let me rephrase the question, Mr. Black. Another aspect of this comfort care is so those last moments are not ones of suffering.
Object, Your Honor.
Okay.
There's no standard of care discussed here.
Sustain.
Witnessing your patient suffering, well, let me backpedal a little bit for a second here and ask you this. You mentioned your pain scores and some of the factors that went into that. Do you recall that testimony?
Yes, sir.
Okay, Mr. Black, in light of that, when someone's on a ventilator and then they are suddenly taken off, there's a significant drop in the oxygen levels that that person is breathing on, correct?
Objection, Your Honor.
I don't know,
We've had
There's-
this discussion. Sustain.
okay. Based on your training and experience, sir, you know that there's a significant drop-off when someone's taken off a ventilator as it relates to oxygen, correct?
Object, Your Honor. This is anecdotal, and
Yeah,
it's
I
patient to
understand.
patient.
I'm going to permit the question.
You can answer.
So the ventilator was capable of delivering any, amount of oxygen.
Stop,
So I don't know that that's the case.
stop. The question is, in your experience, is that the case? Is the answer no? Or is the answer yes?
In cases, yes. In cases, no.
Okay.
And that would be in cases where, of course, the oxygen level were set at approximately 100 or above 21%, correct?
That's correct, sir.
So that's what you mean, that 21% level is what we're breathing in, for example, this room, correct?
Exactly.
And if a patient's oxygen is above that, there's going to be a significant, well, if the patient's oxygen is at 80 or 100%, there's going to be a significant drop-off, correct?
That's correct.
And that's going to take some significant adjusting to, correct?
Object.
Yes, it's going to be very difficult.
It's sustained, you don't have to answer the question.
Now, sir, in addition to that, there are vasopressors that are keeping many of these patients alive, correct?
Yes, sir.
Now, well, actually, I'll get into that a little bit further, but once how fast do vasopressors, once you turn them off,
Object,
actually?
Your Honor, out of the scope.
Well, it's an open cross, but sustained.
All right, let's get down to Ms. Walls. I'd like to discuss that for a moment. I thought you were talking about, sorry. Now, you mentioned that Ms. Walls was Jordan Blair's patient, correct?
That's correct.
And it was your understanding that this patient was actively dying on life support, correct?
That was my understanding at that time, sir.
Okay. And the family, as far as you're aware, wanted to withdraw support, correct?
That's what I was told.
And this, in your mind, once a family makes that decision, especially someone who is actively dying, like Ms. Walls, that is something that you try to do rather quickly, correct?
Absolutely. So anytime the goal of care were to change, it would be something that you would want to carry with great respect and urgency.
And in reference to that, for that reason, time is of the essence. Wouldn't you agree?
Absolutely.
Now, sorry, I just want to find something that you were asked about during direct, if I can have just a second. So on Ms. Wall's case, I won't get too much into her condition because she wasn't your patient. But you mentioned that the order came in by Dr. Husel, correct?
He verbally told me the order.
And that at some point you heard that the order had been rejected by the pharmacy, correct?
So there was, when I was in the room preparing to give the medication, I saw that on screen.
And you went ahead and gave the medication anyway because in your, according to your direct testimony, in your opinion, you thought that the pharmacy would just come and talk to Dr. Husel and he would explain more about the patient's condition, correct?
That was my assumption, yes.
And you had seen this before, where the pharmacy had come and requested more clarification after rejecting an order, correct?
I had seen that once before on a rejection like that, but there were times where there were many times where I'd seen the pharmacy clarify an order, and Dr. Husel would give his rationale, and then they would proceed with the order.
So based on what you knew from your training and experience, and your also your understanding of the process, you felt comfortable administering the meds at that time, correct?
At that time, I had a great confidence in Dr. Husel's decision-making, and I was okay to do that.
Okay. And you mentioned that he was not available, and that's because he got called away for an emergency intubation at that time, correct?
That's correct.
So he was off saving a life while allegedly,
That's not a record.
well, it was an emergency situation, correct?
Yes, sir.
And an intubation is a life-saving measure, correct?
Yes, sir.
So he was not available because he's off saving someone's life, correct?
That's what I understood, sir.
Now, let's discuss Ms. Penix for a moment. Ms. Penix had, Ms. Penix was a very, very sick woman. Wouldn't you agree?
Yes, sir, she was very sick.
And things can change rather rapidly at the ICU, correct?
Very rapidly.
In fact, you're aware that the ICU is the sickest of the sickest patients that go there, correct?
Yes, sir.
In fact, IC stands for intensive care, does it not?
It does, sir.
Now, in light of that, sir, you had, Ms. Penix had stabilized for a certain point, and you thought it was safe for the family to go home, that Ms. Penix would make it through the night, correct?
At that time, she seemed very stable, and that was my observation. Yes, sir.
However, unfortunately, at some point, she took a turn for the worse.
Yeah, very quickly.
And so much so that you thought that death was imminent.
Object.
Sustain.
You thought that it was important enough to call the family back, correct?
Yes, sir.
And when I say important enough, I mean her condition was bad, correct?
She was very unstable.
And she was declining, correct?
Yes, sir.
And it's at this point when the family arrived, correct?
Yes, sir.
And before you ever called Dr. Husel, a family member had come to you and asked you to make sure she was comfortable, correct?
That's correct, sir.
So the family was concerned about comfort care, as far as you're aware.
Yes, sir. They seemed concerned about that.
And they seemed very concerned about her pain, correct?
They were concerned about her pain, and also the feeling of struggling to breathe was very concerning to them.
In fact, they told you that was her biggest fear in life, correct?
Object.
You say sustain.
I'm offering it not for the truth of the matter asserted, but for effect on this listener and what he did next.
No. You're asking for a statement. It's hearsay. Sustain.
Now, sir, when you speak to the family, one of the things that you look for, or one of the things that you take into consideration for your care are, of course, the family's wishes.
Sir, I believe most of the time we were trying to understand the patient's wishes for the family.
That's what I was going to get to next, but I'll start there. One of the things that you want to learn, of course, are what the patients would have wanted, correct?
Yes, sir.
And by way, and at this time, Ms. Penix was not verbal, she couldn't speak, correct?
That's correct.
And the only way that you would know that would be through the patient's family, correct?
That would be the best way to find out in that case.
Because of course, they knew her best.
Correct.
Okay. Now, before you told the family to go home, I think you mentioned that it was just her husband and granddaughter, is that correct?
That's my recollection, sir.
But this time, when they were asked to come back, a lot more family members came?
Yes, sir. I think maybe 4 to 6 more.
Okay. And you understood that to be because they knew they were coming to say their goodbyes, correct?
Yes, sir.
Now, you found out during the course of all of this that Ms. Penix's greatest fear was suffocation, correct?
Object, Your Honor.
Sustained.
Now, you were asked about paralytics, were you not?
Yes, sir.
And it's your understanding that the paralytics wear off after approximately...
Object, Your Honor, outside of the scope of practice.
It's not...
Okay, I haven't heard the whole question, finish your question.
Sure. Mr. Black, through your training and experience, you understand that paralytics wear off approximately 30 minutes after being administered.
Your Honor, continue objection.
With the objection, do you know the answer in your practice?
I think it would depend on the certain medication, but so I don't know.
Okay. You're aware, sir, that that she was extubated after 48 minutes of having received this medication, though, correct?
Yes, sir.
And that's past 30 minutes, correct?
Object, Your Honor.
48 minutes is,
He's already stated he doesn't know.
All I'm asking is that 48 minutes is after 30, excuse me.
I understand,
Okay.
but they're asking sustained.
Okay.
The jury knows the difference.
Okay. Now, you talked about, let me backtrack a little and set up the scene for a second. When the family members arrived, you mentioned that they had come to you and asked you to make her comfortable, correct?
they were concerned about her comfort, yes, sir.
Okay. And that is, subsequent to that is when you called for Dr. Husel to come to bedside, correct?
Yes, that was prior to calling Dr. Husel to the bedside.
Okay. And when he got there, that is when you observed him have his talk with the family, correct?
Yes, sir.
Now, it's your understanding that Dr. Husel is incredibly meticulous, correct?
Yes, sir.
In fact, you had told the police that he was meticulous and he was very cautious with his talks, correct?
Yes, sir. He didn't enter this conversation quickly or lightly. It was only in critical conditions like this where the patient had reached a very unstable condition.
And in fact, you had advised the police that most doctors bring it up sooner, and it wasn't until death was pretty evident.
Okay, time out. I have a question out there. The objection?
I don't think it's relevant what he told the police about most doctors.
They've been discussing other doctors' practices this whole trial.
Okay.
Well-
Sustain then.
Thank you. Thank you.
Okay. And, well, I'd like to ask him about his training and experience as it relates to this. May I?
I haven't heard the question.
Mr. Black, based on your training and experience, would you agree that most doctors that you've observed bring this talk up sooner than that of Dr. Husel?
Object.
Permitted.
Yes, sir.
And it's your understanding that Dr. Husel only has this discussion when death is pretty evident, correct?
At that time, that was my understanding, sir.
Okay. Now, when he was giving this talk, what was Dr. Husel's demeanor?
Are you asking?
Respectful.
Are you asking the one witness? Means the one victim.
I'm asking about Ms. Penix, the only one that he was. I'm sorry, can you answer that again?
I believe he was, respectful would be the first word that comes to mind, and patient with understanding or with explaining Ms. Penix's condition to the family.
Okay. And when he brought up you as an example in your size, that was in relation to the potential of Ms. Penix crashing, correct?
Yes, sir.
Okay, so if Ms. Penix would crash, your patient, you would be the one assisting in the CPR, correct?
That's correct, sir.
So this was an actual scenario. You weren't used as kind of like a figure in this talk, correct?
Yes, sir.
Okay. No, you had never seen Dr. Husel talk to other patients and point at you in the hallway and say, you see, Haas over there is going to be doing this CPR or something like that, correct?
Nothing like that, sir.
Okay, so in light of that, there was nothing that Dr. Husel was telling this family in relation to you that, of course, would not have been accurate, correct?
That's very correct.
Sir, when you gave the pain meds to Miss Walls, it was your intention to be giving comfort care for Miss Walls, was it not?
Yes, sir.
And it was your intention to free her from pain, correct?
Yes, sir.
And it was your intention, knowing that all life-saving measures were stopped, that you wanted her last moments to be of peace and dignity, correct?
Yes, sir.
And as it relates to Ms. Penix, your intention when you administered that dose was to give her comfort, correct?
Asked and answered, Your Honor.
Ms. Walls.
It's a different witness, but overruled.
Your intention was to provide comfort care, correct?
Yes, sir.
And your intention was to alleviate the family's concern of her suffocation?
Object.
Sustained.
You testified a moment ago that one of the concerns that the family had was her not being able to breathe, correct? Do you remember that?
Yes, sir.
Okay. And one of the issues, one of the concerns when you gave when you administered the drugs to Ms. Penix was to alleviate that from happening, correct?
Yes, sir. So there's a psychosocial aspect to this as well, and that she, her family had, so that she had a great fear of the feeling of suffocation or not being able to breathe. And so there was an anxiety portion of this as well that seemed to be very specific to this patient.
Okay. And that is Ms. Penix, correct?
Ms. Penix? Yes.
Sir, it was never your intention to harm Ms. Penix, was it?
Oh, of course not.
And it was never your intention to hasten her death, correct?
Absolutely not.
And I forgot to ask you about the palliative care training that you received and the end-of-life training. Part of that course also included ethics, correct?
I believe so.
And part of the ethics course taught you about the principle of double effect, did it not?
I believe that was in the course, yes, sir.
If I can have just a moment, Judge, I may be done.
You may.
Now, one last thing on the paralytics. You had also, as it relates to Ms. Penix, you had noticed that through the charting and through her vitals, that of course the paralytics had worn off, correct?
Object, Your Honor.
Sustained.
Calls for medical.
After giving Ms. Penix's care, at that time, after she passed away, her family thanked you and hugged you, correct?
Yes, sir.
I have no further questions.
Ms. Grubb?
Hi, Wes. Thanks for hanging with us.
Hi.
So let's turn back to the palliative care training that you did receive. There was some discussion about aggressively treating people in pain or dying people with pain medication, correct?
Yes, ma'am.
Okay. Did the trainers go into specific scenarios and specific drugs and talk about what would be appropriate for a specific case?
No, ma'am.
Okay. I believe you testified previously that there was no dosage training on narcotics during nursing school. Is that correct?
Objection, this has been.
No, it would have been,
And leading.
Okay, it's transitional, I'll permit it.
it was just sort of the general indication or the classification of the drug more than any sort of dosing
Okay,
specific.
all right. And had you taken the time to go and read all about fentanyl and Versed and the synergistic effect on a person?
Objection, this has been asked and answered during direct.
No, I asked, it's redirect, and I did not ask whether he had read about it.
Okay.
She did ask about this.
It's within the scope, I'll permit it.
I don't believe so, ma'am.
Okay. Do you understand any of did you understand at the time that these doses were given, all of the contraindications or complications?
Leading.
Your Honor, I'm
Finish the
asking,
question.
did you understand the complications or contraindications of fentanyl and/or Versed?
Objection.
Sustained. It is leading.
No further questions?
Okay, thank you kindly.
Thank you, Judge.
Thanks, Wes. Appreciate it.
Thanks, Janet.
You need to take it out. I got it cleared. Call your next witness.
Your Honor, may we do a quick sidebar report about something? on the
Yes.
record?
This one's up and down.
Okay. You ready there? Ladies and gentlemen, I'm gonna send you to lunch early. We gotta do something. Let's come back at 12:45. It's an hour and 15 minutes for people to transact their business and such. Get your lunch in, and we'll get started at 12:45. So with that, remember the admonition, you're to lunch.
All rise.
Anything for the record, Ms. Grubb?
Nothing this time, Your Honor.
Mr. Bias?
Nothing from us.
Okay. 12:45, everybody.